Assalamualaikum and a very good day to Dr. Asma and my fellow friends. I'm going to present about my orthodontic case presentation. So I divide my presentation into two parts, which is the first one is case A and the second one is case B. Without further ado, let's start about case A. This patient name is Miss SG. She is a 25 years old Indian female. She came with a complaint of not satisfied with the teeth alignment. Medical history, she generally has good health with no known medical illness. This is the extraoral photos of the patient. For the extraoral examination, this patient has skeletal pattern class 2 with a convex profile and lower front foot mandibular plane angle. She has moderate lower anterior facial height, and for the facial symmetry, she has mild asymmetry. As you can see on the picture, the left side of the cheek is slightly bigger than the right side. For the TMJ, however, I cannot assess by just looking at the picture. And she also has a competent lips to resting. For the intraoral examination, generally she has a quite fair oral hygiene with healthy periodontal tissue with no signs of inflammation or infection at all mucosa. For the tooth quality, there's a fissure sealant at 1/6, 2/6 and 3/6 with no caries detected at all teeth. Interestingly, for this patient, she has a peg-shaped lateral 1-2. For the teeth erupted, for upper arch, all permanent teeth are erupted except all third molars 1/8 to 8 and also 1/3. For the lower arch, all permanent teeth are erupted except 3/8 and 4/8. For 1/3, for the teeth unerupted, is 1/3 and all third molars. Based on the OPG, all these three teeth are all impacted. For the arch shape, for the upper one is a U-shaped arch and the lower one is a slightly square-shaped arch. Okay, so this is the upper arch, the intraoral of the upper arch. For the label segment of the upper arch, there's a mild spacing about 3 mm and the moderate crowding of just 7.5 mm with 2-3 displaced buccally, 2-2 inclined palatally and 1-2 rotated mesopalatally. For the buccal segment, both right and left are well aligned. For the lower arch, at the label segment, there's a severe crowding about 9.5 mm with 4-2 displaced lingually, 4-1 rotated mesolabially, and 3-2 inclined lingually. Both right and left buccal segment are well aligned. Okay, this is the photo of the teeth in occlusion. She has a class 2 division 1 class 2 division 1 incisor relationship with increase of a jet about 5 mm, which is located at 1/1 to 4/1. However, this patient has normal overbite about 30%. I cannot assess whether the overbite is complete or incomplete trauma or a trauma based on the picture above. The lower midline shifted to the right about 2 mm. Okay, this is the buccal segment. For the canine relationship at the right is unclassified due to the impacted 1/3, and at the left is class 2 half 1/4 unit. For the molar relationship, both right and left have class 2 half unit. She also has a crossbite between 1/2 and 4/3. This is the OPG. I cannot see whether the date of the taken due to the poor quality of the image. Generally, this OPG has quite fair quality of contrast. The condyles cannot be seen clearly, and no bone loss can be seen from the OPG. All the penalties are present in this OPG, and no radiolucency or no radiopacity that can suggest any pathology can be seen from this radiograph. 1/3 seems to be impacted in between the middle half of the root of 1/4 and 1/5, and all third molars root are not fully developed yet. This is the second radiograph that is taken, which is the standard occlusal view. Actually, the standard occlusal view radiograph is taken to further investigate the location of one tree, whether it is located at the buccal or palatal. So, based on the standard occlusal view is taken along with the OPG so that the slope technique can be done. So, based on these two radiographs, the one tree seems to be located at the palatal side between the 1.4 and 1.5. Next is periapical. Okay, periapical is taken to assess the periapical status of the adjacent teeth of one tree, especially 1.4 and 1.5. As you can see, the one tree is impacted in between the middle half of the root of 1.4 and 1.5 due to the impaction of the one tree. There's the presence of root resorption of 1.4, almost half of the root, and at the 1.5 only at the apical third of the root. Okay, this is the lateral shaft. Okay, for the tracing of the lateral shaft, I use um the the software on the internet to trace the lateral shaft, which is called webshaft.com. So this is the tracing that I did. This is the interpretation of the lateral self. Okay. The SNA value of this patient is higher, which is 92 degree as compared to the normal value, which indicates that this patient has prognatic maxilla. For the SNB, this patient has normal SNB value, which is 81 degree, which shows that this patient has normal mandible. For the NNB, this patient has an increase of the NB value from the normal value, which is 11 degree. It shows that this patient has class 2 skeletal relationship. For the SNMSP, this patient has normal SNMSP value, which is 9 degree as compared to the normal value. Okay, so when SNMSP is in the normal range, the Eastman correction can be applied. So from the SNA value, there's an increase about 11 degree, so the corrected A and B will be 3.5 degree. So after the correction, the A and B value shows that this patient will have skeletal pattern class 1 as compared to before correction, which this patient have class 2 skeletal. For the MMPA, this patient have high MMPA, which is 55 degree as compared to the normal value. This might be due to the slight posterior growth of rotation of the mandible, which leads to the increase of the lower anterior facial height. For the UIMSP, is 123 degree, which is high as compared to the normal value, shows that this patient has proclined upper incisor. And for the LIMNP is 101, which is also high as compared to the normal value. It shows that this patient has proclined lower incisor. And for the IIA is 112, which is very low as compared to the normal value, which is it can indicate that this patient has reduced interincisal angle. And the last one is LAFH is 58 degrees, which slightly high than as compared to the normal value, which shows that this patient has increased lower anterior facial height. For the etiology of this case, I have three etiology. Okay, the first one is skeletal pattern class 2. Second one is dental-alveolar discrepancy, whereby all the teeth are quite big as compared to the arches. And the third one is the pig-shaped lateral. Okay, for the pig-shaped lateral, you might wonder why I put here. Okay, for the pig-shaped lateral, actually it is responsible for the impaction of the 1/8. Okay, based on the guided theory for canine, for the eruption of the canine, okay, the distal surface of the lateral incisor is thought to guide the eruption of the canine. So based on this statement, when there is any abnormality in size or shape of lateral incisor, it can cause the impaction of the adjacent canine. So in this patient, she has a peg-shaped lateral of 1-2. Okay, so when there is peg shape, so the size of the 1-2 is quite small as compared to the normal 1-2. So that is why the 1-3 is impacted inside the bone. So that is one of the etiology of this case. And the IOTN for this patient is 5i due to the impaction of the canine. Okay, this is the summary of this patient. Patient is a 25-year-old Indian female. Came with a chief complaint of not satisfied with the teeth alignment. Patient has a class 2 division 1 incisor relationship on a class 2 skeletal pattern with low FMPA and a convex profile. Patient also has peg shape. I'm sorry, I think that's a grammar error. Patient also has a peg shape of 1-2 and impacted 1-3. There is a mild crowding as well as moderate crowding on the upper arch and severe crowding on the lower arch. In occlusion, she has an increase of a jet of 5 mm and a normal overbite of 30%. The canine relationship is unclassified on the right side and the class 2 1/4 unit on the left side. She also has a cross bite between 1-2 and 4-3. Molar relationship for both right and left side is class 2 half unit. The IOTN for this patient is 5i. The problem list, there's the 9 problem list. The first one is peg shaped letter of 1-2. Second, impacted 1-3. Third is skeletal pattern class 2. Fourth is mild spacing and moderate crowding of upper labial segment and severe crowding of lower labial segment. Fifth is class 2 division 1 incisor relationship. 6 is increase of a jet of 5 mm. 7 is class 2 1/4 unit canine relationship on the left. 8 is class 2 half unit buccal relationship of right and left, and the last one is lower midline shifted to the right. So the aim of this treatment is first to do the composite build-up of 1-2, and the second one is to surgically expose of 1-3 and orthodontic traction. I'll explain later about the aim of treatment of 1-3. And the third one is to correct the skeletal pattern to class 1. And fourth is to close up the space and to relieve crowding. Fifth is to correct the incisor relationship to class 1. Sixth is to reduce the overjet and to reduce the canine relationship to class 1. Next is to correct the buccal relationship to class 1, to correct the lower midline, and also to correct the crossbite. Okay, so for the aim of treatment of 1-3, I previously stated to surgically expose the 1-3 and orthodontic traction will be done after the surgically exposed of 1-3. So there's a few treatment option for impacted 1-3. Is first is we don't have to do anything, but in this case the 1-3 is already caused the root resorption of 1-4 and 1-5, so we cannot just leave it there and further cause more root resorption. So we have to do something about it. So it's either we just remove it, surgically remove it, and also or we surgically expose it and we do the orthodontic traction or orthodontic alignment later. If this patient has a very good cooperation and a very good compliant, we can do the surgery and also orthodontic traction. And if this patient are not very cooperative, are not that good compliant, we can opt for surgically remove it. But I just put the aim of the treatment first to surgically expose it. This is because so there's a few criteria to determine whether we can do this treatment or not. So we have to see, the first one is we have to see the position of the impaction of 1-3. In this case, the impacted 1-3 has a favorable position, which is in the anterior posterior position. The 1-3 is far from the midline, so it is quite more easier to do the treatment. And in the apical position, it is not exceed the second root of the root of the second premolar. So in the criteria is indicate that the impacted 1-3 must not exceed the second premolar, and in this case it is not exceed the second premolar, so we can do the surgical expose of 1-3 and orthodontic traction. I hope you understand my explanation. If you don't understand, you can ask later. For the treatment plan of this patient, general treatment plan would be oral health instruction, which is to reinforce the patient how to brush the teeth when wearing the appliances in the mouth and how to floss the teeth. And the second one is oral health education, which is to educate the patient about what is plaque and the consequences of it when after wearing the appliances. The third one is the full mouth scaling and prophylaxis. The fourth one is the refer to the oral maxillofacial surgery for consultation for surgical expose of 1-3 and also restorative department for composite build-up of 1-2. The orthodontic treatment plan would be upper and lower fixed appliances, and the retention treatment plan would be upper and lower wholly retainer. Okay, that is all from case A. For the case B, this is the detail of the case B. She is a 14-year-old Malay girl complaining that her upper front teeth going inwards. She presented with a class 2 division 2 with overjet of 2 mm and overbite of 80% complete to the palate. Okay, from the detail, she has quite a very deep bite, which is 80% complete to the palate, and due to the overbite, which is complete to the palate, it might cause trauma. So we have to further assess of the intraorally whether this patient has trauma to the palate due to the overbite, and also she has also reduced overjet, which is only 2 mm. Okay, this is the intraoral photos. As you can see, the upper front tooth, which is the 1-1 and 2-1, is slightly retroclined, and a very deep bite, increased overbite. And also I have to mention that 1-2 is slightly proclined as compared to the other teeth. This is the design that I did for the URA. Okay, for the Z spring, I put at the palatal side of 1-1 and 2-1 to procline the upper teeth, so it can act as a active components of the URA, and labial bow, it can act as both active and retentive component of the URA. For the labial bow, it can actually retrocline back the 1-2 inside and also act as a retentive arm. For the posterior bite plane, I put posterior bite plane to actually open up the bite so that the upper and lower front tooth has a space so that the Z springs can freely push the 1-2, 1-1 and 2-1. And Eden class, I put at the 1-1-6 and 2-6. It can act as a retentive arm for the retention. And last one is acrylic base plate and act as a encourage. So that is all from me. Thank you so much. If you have any question, you can ask in the discussion. Thank you.